Uh, Good afternoon, everyone. I'm Chan. For this month, College of Physicians weekly webinar, we will be focusing on gastroenterology and hepatology. Today's topic will be non-alcoholic fatty liver disease and metabolic associated fatty liver disease. We are very honored to have Prof. Dr. Raja Effendi as our chairperson. He is the Dean of Medicine and a consultant in gastroenterology and hepatology at UKM. He also acts as the immediate past president of the Malaysian Society of Gastroenterology and Hepatology, and currently the treasurer of Asia Pacific Association of Gastroenterology. Without further ado, over to you, Prof. Effendi.
Good afternoon. Thank you. Happy New Year. Thank you, Dr. Chang. It's a pleasure to chair the very first session, the Gastroenterology Hepatology webinar from the College of Physicians of Malaysia. And today we're going to discuss Nafld and Mafld, non-alcoholic fatty liver disease, and metabolic associated fatty liver disease. And we have four outstanding key opinion leaders in this webinar today. I think without further ado, I would like to invite the very first speaker, Professor Chang Wah Keong. He's a consultant gastroenterology pathology at the Medical Specialty Centers. He's really key opinion leaders in Nafld and Mafld, has published numerous in high impact journals, and also members in the Asia Pacific working for Nafld and gut obesity, Asia Go Asia, and also as members in Global NASH. He's the right person to discuss with us about the overview of Nafld and Mafld. Is it the same disease entity? So the stage is yours, Professor Chang Wah Keong.
Thank you very much, Professor Effendi, for your very kind introduction. Very good afternoon to friends and colleagues, ladies and gentlemen. It's really my pleasure to be here today for the week one of the College of Physicians Malaysia webinar and on Nafld and Mafld. So just let me share my screen. The topic that has been given to me today is overview of Nafld and Mafld. Are these the same disease entity? So I'd like to start by looking at the history, whereby the term non-alcoholic steatohepatitis was actually first coined by doctors at the Mayo Clinic who describe a liver condition that mimic alcoholic hepatitis, which can progress to cirrhosis. And this patient did not have any significant alcohol intake. However, they were moderately obese, and many of them had obesity-related diseases such as diabetes. Fast forward 20 years later, it has been commonly used, the term non-alcoholic fatty liver disease or Nafld has been commonly used. And this encompasses a spectrum of liver condition that's characterized by excess accumulation of fat in the liver, and it is related to overnutrition. For a strict definition of Nafld, significant or excessive alcohol consumption and other diseases must be excluded. This is the spectrum of Nafld. At one end is simple steatosis. And as we move to the right, NASH or non-alcoholic steatohepatitis is the more severe form of the disease that's defined histologically by the presence of, in addition to hepatic steatosis, the presence of lobular inflammation and hepatocyte ballooning. Patients with NASH are those who are at higher risk of developing liver fibrosis and can progress to liver cirrhosis. Patients with NASH, especially in the presence of advanced fibrosis or cirrhosis, are at increased risk of developing liver cancer as well as decompensated liver disease. Across the entire spectrum of Nafld, patients are at increased risk of cardiovascular disease. This is because of the close association of Nafld with the metabolic syndrome. This is a study that was conducted in Hong Kong. It was a study on subjects who were randomly selected from the Hong Kong census database. And the presence of significant hepatic steatosis was assessed by proton magnetic resonance spectroscopy. And patients also underwent transient elastography to assess for liver fibrosis. As you can see here, there's a high prevalence of Nafld in the general population. 27% of the subject had Nafld. However, only a very small but significant proportion of patients had advanced liver fibrosis at about 3%. A study in Malaysia has also shown that the prevalence of Nafld in the general population to be about 22%. And as you can see here, the prevalence of Nafld increases as the number of metabolic syndrome criteria increase. Is 5% in those who do not have any criteria of the metabolic syndrome, and this increases according to the number of metabolic syndrome criteria to as high as 80% among those who have all 5 components of the metabolic syndrome. So we can see that Nafld is in fact the liver manifestation of the metabolic syndrome. This is the natural history of Nafld. Its annual incidence is estimated to be about 3 to 4%. And 25% of patients with simple steatosis progresses to NASH and have some fibrosis progression over 3 years. Patients with NASH progress in terms of liver fibrosis at a faster rate compared to patients with simple steatosis. And once cirrhosis has developed, the incidence of liver cancer has been estimated to be about 1 to 4% per year. I would like to highlight that although NASH is the more severe form of Nafld, but it is really the degree of liver fibrosis that predicts liver-related complications and mortality in Nafld patients. As you can see in this study, patients who have stage 2 fibrosis, or what we call significant fibrosis, are at about 10 times higher risk of developing liver-related mortality during follow-up. And the risk increases exponentially, so much so that those patients with cirrhosis are over 40 times more likely to die of liver-related complications. So we have been using the term Nafld for many years now. However, there are some fundamental issues with this term. First of all, there may be more than one cause of chronic liver disease in an individual patient. For example, we often see patients who have fatty liver and is obese and also consume more than a modest amount of alcohol. We also often see patients with chronic hepatitis B infection who also have fatty liver that is related to obesity. So if you were to use the term Nafld, these patients would have been considered not to have Nafld. Instead, they have alcoholic liver disease as well as, and on the other case, chronic hepatitis B infection. The other issue is that the term Nafld does not attribute the condition to its underlying etiology. We know that the majority of cases of Nafld are related to obesity and the metabolic syndrome. Because of these fundamental issues, Eslam and colleagues have proposed the term metabolic dysfunction associated fatty liver disease, or MAFLD. Is diagnosed in adults who have hepatic steatosis either by imaging, blood biomarkers, or based on liver histology if the person is overweight or obese, has type 2 diabetes mellitus, or has at least 2 metabolic risk abnormalities. The metabolic risk abnormalities include the standard criteria for metabolic syndrome. And in addition to that, elevated HOMA-IR and elevated plasma HSCRP level. So to compare the two terms, MAFLD and NAFLD, this is the summary. In MAFLD and NAFLD, both require demonstration of fatty liver. However, in MAFLD, you do not need to exclude other causes of chronic liver disease, such as excessive alcohol consumption, viral hepatitis, and other liver disease, as well as drugs that may cause fatty liver. You do need the presence of either overweight, obesity, type 2 diabetes mellitus, or at least 2 other metabolic risk abnormalities. In other words, MAFLD uses a positive definition, whereas the term NAFLD uses a negative definition. So since the introduction of the term MAFLD in 2020, this is one of the landmark paper, and as you can see here, it has been cited more than 800 times. And if you look at the number of publications with the term MAFLD in Google, you can see that in 2020 itself, there were nearly 500 publications, and just last year, 1,700 publications. And just within 6 days this year, there are already nearly 50 publications. So this is really a hot area. To summarize, I'd like to cite this paper by Professor Vincent Wong, which I thought was a very good paper to give us an overview of the current status of Nafld versus MAFLD. If we were to look at the criteria for Nafld and the criteria for MAFLD, more than 80% of patients would meet the criteria for both Nafld as well as MAFLD. However, on one end, there are about 5 to 8% of patients who would meet the criteria for Nafld but not MAFLD. These are patients who have fatty liver, however, they do not have any of the metabolic criteria. These patients usually do not have significant liver disease. They have very mild liver disease. Whereas on the other hand, you have patients who meet the criteria for MAFLD but not Nafld. These constitute about 5 to 8%. And these patients are those patients who have significant hepatic steatosis on top of other causes of chronic liver disease, such as excessive alcohol intake, chronic hepatitis B and C infection, etc. You can imagine that these are the patients who tend to have more severe liver disease. And in fact, there has been studies already showing this. In short, the term MAFLD has better clinical utility compared with the term Nafld. So the term MAFLD has already been endorsed by the Asia Pacific Association for the Study of Liver based on this clinical practice guideline that was released in 2020. The term has also been endorsed by the Latin American Association for the Study of Liver, as well as by the Middle East and North Africa. And closer to home, the Malaysian Society of Gastroenterology and Hepatology has also endorsed the term Nafld, and the term has also been endorsed by an international patient group. The Clinical Practice Guideline on Management of Type 2 Diabetes mellitus, which was published early last year, has also got a section on fatty liver now for the very first time, and the term MAFLD has also been mentioned in the clinical practice guideline. So I just want to touch a bit about Nafld or MAFLD in patients with diabetes. Diabetes is a very important risk factor for more severe Nafld. So based on this study on more than 1,000 biopsy-proven Nafld patients, diabetes mellitus was recognized as a risk factor for NASH as well as advanced liver fibrosis. And based on this study that was conducted in our hospital, using transient elastography, over 70% of patients attending the diabetes clinic had significant hepatic steatosis, and over 20% had advanced liver fibrosis. And among those patients who has liver stiffness measurement more than 8 kilopascal who were referred for further assessment in our gastroenterology clinic and who underwent liver biopsy, majority of them had NASH and some degree of liver fibrosis, and over 1/3 of them had advanced liver fibrosis on histology. So the inclusion of fatty liver in the type 2 diabetes clinical practice guideline is really an important step, and it has been cited by this paper published by the Economic Intelligence Unit in collaboration with the ISO International Liver Foundation as a potential strategy in identifying and managing a patient with more severe MAFLD. There are also many other strategies. If you are interested, you can actually refer to the document by using the QR code that is shown here. There are still some issues with the term MAFLD. A group of experts from the United States and also from European countries has suggested that the new term may actually confuse stakeholders. However, there are also a group of experts as well as patient group that believe that the term Nafld is stigmatizing patients because of the presence of the term alcoholic in its name, as well as the presence of the term none makes the disease looks less important. There's also a concern about the introduction of MAFLD affecting ongoing clinical trials. All current ongoing clinical trials actually use the term NASH. However, this has not been addressed with the new term MAFLD by consensus, although it's proposed that we should still keep the term steatohepatitis and assess the disease severity based on activity score and fibrosis score. There has also been concern about the ambiguity in definition of metabolic syndrome. Essentially, it is using the definition for metabolic syndrome. And there's also party that suggests that more complete understanding of the disease would be needed for a change in nomenclature. However, it's debated that, at what point do we consider that we have enough understanding of a disease to give it a new name? I would like to cite this paragraph in this paper by Professor Vincent Wong. So there are compelling reasons to have a better name for what we call Nafld for decades. For the most common disease in our field, it is appropriate to use a name that says what it is, rather than what it is not. However, the sentiments surrounding the lack of engagement with different stakeholders are well taken. And this is actually a recent paper that is a consensus statement published in Natural Review on Gastroenterology and Hepatology just earlier this month, consisting of expert panel from 16 countries and endorsed by 110 organizations from 59 countries at the time of publication. And this included the Ministry of Health Malaysia, the Malaysian Society of Gastroenterology and Hepatology, and the Malaysian Endocrine and Metabolic Society. So one of the recommendations is that professional society and other relevant stakeholders, such as patient organization, should collaborate on a transparent process to carefully reconsider the nomenclature of fatty liver disease, with special attention to the benefit of and barrier to changing the name of Nafld. So as I'm speaking now, there's an ongoing process involving all stakeholders to come to a consensus to accept a new name for this disease. And hopefully within this year, we will be able to see a new name to this condition. So that's all for my talk today. Would you prefer the term Nafld or Mafld? I would appreciate your comment in the comment box. And thank you very much for your kind attention.
Thank you, Professor Chan Wah Keong. A great start for Nafld versus Mafld. And we will take all the questions until the end of the webinar. The next speaker is another outstanding senior consultant hepatologist at the Department of the Hepatology, Selayang Hospital. Dr. Tan Sok Siam is also a past president of the Malaysian Society of Gastroenterology and Hepatology and worked very hard during our Asia Pacific Digestive Week.
Sorry, can you hear me?
Yes, yes, indeed.
Okay, just now your audio, I missed a lot of your audio. Thank you very much anyway. Thanks, Effendi, for recommending me to join this webinar, and thanks to the College of Physicians for inviting me. So my task is to talk about triaging metabolic dysfunction associated fatty liver disease, Nafld, for optimal care. So as Professor Chan has alluded to, Nafld or Nafld fatty liver disease is a prevalent liver disease. And the prevalence you will see in terms of the percentage will vary a bit, but it depends on how it was diagnosed. In this paper, diagnosed by ultrasound, Malaysia is supposed to have 38.5%. And Nafld in diabetes, as Professor Chan said, is very high and is close to 50%. Given that the close association between fatty liver disease and type 2 diabetes and obesity, which we know these two diseases are increasing, we can surely assume that the prevalence of fatty liver disease, Nafld or Mafld, is likely to continue to increase. This slide shows you a little bit about the pathophysiology of fatty liver disease, Nafld. It's actually a complex interactions between the patient's genetic determinants. There are few important polymorphisms being described, and also associated comorbidities. You've heard about type 2 diabetes, obesity, is also associated with obstructive sleep apnea, polycystic ovarian disease, and also gut dysbiosis. And also environmental and behavioral factors have impact on the pathophysiology of Nafld, socioeconomic factors, and the diet and exercise of the individual. Actually, Nafld has a variable and at times unpredictable clinical course. In up to 20%, they have a rapid progressing disease. I think Professor Chan has talked to you about this condition. So just to stress that Nafld encompasses a spectrum of liver conditions. A normal liver, when it starts to accumulate fat, more than 5% fatty infiltrations, you have steatosis. And steatosis can progress to steatohepatitis. Steatohepatitis is a diagnosis by liver biopsy. You should see inflammation in the liver, ballooning of the hepatocytes, and also these Mallory dying bodies. And steatohepatitis indicates it is a severe liver disease injuring the liver and can lead on to fibrosis. And steatohepatitis is usually not reversible unless there's intervention. And in fact, it can progress, and 2.5% of the individual progress to cirrhosis. With cirrhosis, you can have hepatic decompensation, 2 to 9% chance of getting ascites or variceal bleed within 2 years, HCC 1 to 4% per year. And in our practice, we are seeing these patients as we speak in my ward, in my clinic, and people coming to assess for liver transplantation. So this is a guideline that Professor Chan talked to you about, the Asia Pacific guideline. And it is open access. You can get it from Hepatology International. Just Google that and you get it. So just want to go through the steps of diagnosis. Step 1 of diagnosis is to screen for this disease in patients of high risk. These are patients who are obese, type 2 diabetes, or those with metabolic dysfunction. And you screen to look for fatty liver. And how do you do that? You can do it by imaging or blood biomarkers or by liver histology. And as I think in our situation, usually we do ultrasound. Just bear in mind, ultrasound is less good like doing by transient elastography. Of course, the best is MRPDFF, which is actually not easily available. So ultrasound is still our most frequently used method of diagnosis of hepatic steatosis. And once you have hepatic steatosis, ask yourself, is my patient overweight or obese? And for Asians, it's a BMI of more or equal to 23, or the patient has type 2 diabetes. Then you have presence of Nafld if you have either of these. If you do not have, then you do need to look for the 2 metabolic risk factors that Professor Chan talked about. Screening for non-alcoholic fatty liver disease in type 2 diabetes patient has been shown to be cost-effective in the United States. In this study published in 2020, the screening strategy was in patients with type 2 diabetes over 55, they did an ultrasound and ALT or ST, and if they suspect fatty liver, they proceed to a transient elastography, and if they have stage 2 disease, they are given 1 year intensive lifestyle intervention, or they are given pioglitazone. In both methods of assessing and also treatment is found to be cost-effective compared to no screening strategy. And the ICER is very low, 35,000 or 36,000, much lower than the 50,000 per quality of life, adjusted life year. You've also heard that in Nafld, it is the fibrosis that actually matters. In this study, with more than 600 patients with liver biopsy from US, Europe, and Thailand, followed up for 12.6 years, 33.2% of them died or underwent a liver transplant. If you look at those without NASH, without the steatohepatitis, the blue and green bar, you can see those with fibrosis have a poorer survival than those without fibrosis. And in those with NASH, the orange, the yellow, and the red bar, you can see those with fibrosis, the red line has actually poorer survival compared to those in the orange color line. So fibrosis is very important. And in fact, this systemic analysis, meta-analysis on the 13 13 studies on more than 4,000 patients with liver biopsy diagnosis of Nafld, you can see at stage 2, the unadjusted relative risk for all-cause mortality starts to increase, liver-related mortality increase, liver transplant increase, and all liver events increase. And if you compare those without fibrosis to those with stage 4 is cirrhosis, the all-cause mortality increased by 3.42%, the unadjusted relative risk. For liver-related mortality is 11.13, for liver transplant is 5.42, and for all liver events is 12.78. So hepatic fibrosis is a key prognostic marker of mortality and liver-related morbidity. So this guideline, the Asia-Pacific guideline, the step 2, after diagnosis of presence of Nafld, is to triage by hepatic fibrosis. So you assess for risk of advanced fibrosis assessment. This is by using non-invasive either blood markers or imaging-based markers. So the blood fibrosis biomarkers are the FIB-4, the Nafld fibrosis score, FibroTest, ELF, and ADAPT. The liver stiffness assessment by we can use an MRI or a transient elastography and other elastography, and you can classify them. So the simple blood biomarker fibrosis score, we have FIB-4 and the Nafld fibrosis score. The FIB-4 use the patient age, AST, ALT, platelet count. Certainly, these are all readily available when we see a patient. The Nafld fibrosis score use a bit more, use albumin, the BMI, whether the patient has impaired fasting glucose or diabetes. And you can Google this formula or use your app to count them. So Professor Chan has talked about this management of type 2 diabetes, the 6th edition from Malaysia. And I'm happy to say that in table 3.1, detailed assessment of newly diagnosed patients with type 2 diabetes involves looking for comorbidities like non-alcoholic fatty liver disease. And non-invasive scores such as FIB-4 can be used to stratify patients with type 2 diabetes and Nafld. And this is the formula for FIB-4. You don't need to calculate it. You just Google it for the calculator and plug in the figures and you get readings. And then the guideline also say how to manage them when you have the FIB-4. Is it less than 1.3 or more than equal to 1.3? I will go to this in more detail later. So why do we use FIB-4? It's actually the best diagnostic, has the best diagnostic accuracy for advanced fibrosis amongst all the simple blood-based tests. These simple blood-based tests are using parameters that we have. So you do not need additional cost to get these parameters. And you can see FIB-4 as an RULC of 0.8, the highest, sensitivity of 77.8%, specificity of 71.2, with a negative predictive value of very high, 92.7. So it is good for a public health approach. So FIB-4 less than 1.3 or less than 2 for those who are older than 65 years old, reliably exclude advanced fibrosis with a very high negative predictive value. And FIB-4 also correlates with clinical outcomes. And this has been also studied by the UM group. I think Professor Chan is one of the co-authors. 122 adults with Nafld with biopsies, and 80% of them have NASH. You can see FIB-4 has a highest AUROC compared to other simple biomarkers. And FIB-4 has the highest negative predictive value in our population at 94.3%. And using FIB-4, a kind of 1.3, patients avoiding referral can be 72%. And the false negative result is low at 6%. So back to the type 2 management of type 2 diabetes guidelines, the 6th edition from our country. So first patients with type 2 diabetes or steatosis, you look at the FIB-4. If it's less than 1.3, it's unlikely to have advanced liver fibrosis. If it's more than or equal to 1.3, liver stiffness measurement is required. So these patients should have their liver stiffness measurement. If it's less than 10 kilopascal, it's unlikely to have advanced liver fibrosis. If it's between 10 to 15 kilopascal, they may have advanced liver fibrosis. they require monitoring, and you should consider referring to the gastroenterologist or hepatologist. If the patients have more than 15 kilopascal, it's likely to have advanced liver fibrosis. We should consider referral to the gastroenterologist and hepatologist, and we should consider having HCC surveillance in this group of patients. Or if the liver stiffness is even higher, more than 20 to 25 kilopascal, these are very sick patients already. They are likely to have clinically significant portal hypertension. They should be referred to the gastroenterologist and hepatologist, and we should also consider varicose screening by endoscopy. So those in either a FIB4 less than 1.3 or more than 1.3, but the FibroScan of less than 10 kilopascal, they do not need to be referred, and we just need to repeat these parameters 2 to 3 years. If there is progression, they need to be referred. There's still no US FDA approved therapy for Nafld or Nafld. There are many compounds in phase 2 and 3 developments. They are targeting the lipid carbohydrate metabolism. They are either targeting the lipotoxicity or cell death from the fatty tissue, and targeting inflammation and targeting fibrosis. Some of the drugs, even after in phase 3, they had to be stopped the development as there were negative results. And there are some drugs, the GLP-1 agonists are under investigations, and we are also participating in some of these trials. If you have patients who have significant disease, consider the possibility of clinical trial, please contact us. So ladies and gentlemen, we are living in a pandemic endemic of Nafld. So in that case, what is our preparedness index? So this is a work done with the EASL International Liver Foundation, looking at the preparedness index, policy index score. This is the worst case scenario, this is the best scenario, and this is the middle scenario. And where is Malaysia? Malaysia is here, between the worst and middle scenario in terms of policy index score for our preparedness for the Nafld pandemic. And Professor Chan also told you about this other work that we managed to do. It's a consensus statement about the Nafld public health agenda. So I want to spell out what it's actually what we need. We need leadership for the Nafld public health agenda. We need to have investment in research. We need awareness. We know the awareness from living through the pandemic that we need simple knowledge and simple information. We need treatment and care, and perhaps here is something that we should actually think about further, and is defining and implementing model of care. It designs and implement a local care pathways. It says a multidisciplinary approach is needed. We need equipments, the necessary tool to look after this patient, and expand the use of the research. And of course, we should involve our community and patients, and also policy strategies and whole society approach, and address, this is part of the NCDs, you have to address this together. So ladies and gentlemen, Nafld there's a high prevalence of fatty liver, especially in patients with type 2 diabetes. Not all patients require hepatology care, but not knowing who needs to will lead to inconsistent care and possible poor outcome. So step 1, screen for Nafld in patients with high risk. And then if there is Nafld, assess for fibrosis using FIB4. Therefore, you can stratify for optimal care. Those with high FIB4 above or equal to 1.3, or use a cutoff of 2 if the patient is older than 65 years old. You need to refer to the gastroenterologist or hepatologist. This will also guide evaluation and interventions, which I'm sure Professor Anis will talk about, but this is to share with you. This is a recent guideline last year from America. They also talk about triaging patients management. Low risk is those with a FIB4 less than 1.3. Intermediate is between 1.3 and 2.67, and high risk is more than 2.67. So those with low risk FIB4 less than 1.3, they should be managed by the primary care physician, the endocrinologist, cardiologist, and need the help of a dietitian. Lifestyle intervention is required. Weight loss is recommended if they're overweight or obese. They need structured weight loss program. They may need anti-obesity medication, or they may need bariatric surgery, which you will hear from the following speaker. But pharmacotherapy for NASH is not recommended. However, there's none anyway. Cardiovascular risk reduction is needed, and diabetes care is standard. In those with intermediate risk or high risk, they need to be referred. They need to be seen by the hepatologist together with the other endocrinologists and cardiologists, dietitian, and the primary healthcare. Lifestyle intervention needs to be on again. And weight loss, you have greater need and stronger need for a structured weight loss program, anti-obesity medications, bariatric surgery. Here, patients may need pharmacotherapy for NASH, and we're still looking for one. And cardiovascular risk reduction still continue. And here, in terms of diabetes, the management of these patients could be probably moved from the standard of care to other diabetic medications. Thank you for your attention.
Thank you so much, Dr. Tan, and we will take the questions after the last speaker, and I encourage all the audience to write the questions on the Q&A box, and we move to the next speaker. We have a mixture of gastroenterology, pathology, and we have today Professor Dr. Anis Safura Ramli, the Senior Consultant Family Medicine Specialist, specializing in the chronic disease management. They're very experienced, and mostly, of course, we all listen associated with a lot of metabolic disease. So she's currently also the Deputy Director for the Institute of Pathology, Laboratory and Forensic Medicine I perform at the UITM. So we're delighted to have a representative from the family medicine specialist in dealing with Nafld. So Prof. Anis, we're going to talk to us about lifestyle intervention and managing comorbidities in Nafld. Prof. Anis, the stage is yours. Thank you.
Thank you very much, Prof. Raja Effendi, for the very kind introduction. Assalamualaikum warahmatullahi ta'ala wabarakatuh, and a very good afternoon. First of all, I'd like to thank the College of Physicians, Gastroenterology and Hepatology team for inviting me this afternoon. I am indeed very honored to be here to be talking about this topic on lifestyle intervention and managing comorbidities in Nafld. So this is the presentation outlined. I'm going to share with you in the next 10 to 15 minutes about metabolic syndrome, Nafld, and CVD. How common is Nafld in our clinical practice, especially in my field, primary care? And then we are going to go on to covering the topic today, managing cardiometabolic risk factors and delivering lifestyle intervention in patients with Nafld, and a bit of take-home message afterwards. So ladies and gentlemen, metabolic syndrome, Nafld, and CVD. As we know, the previous two speakers has highlighted to you that Nafld is very, very common in people with multiple risk factors such as metabolic syndrome. So in our Malaysian population, the recommended definition criteria for metabolic syndrome is the JIS 2009, because this is the definition that will pick up more of our Malaysian populations. So Nafld as well as atherosclerotic CVD is actually manifestations of end organ damage of patients or people with metabolic syndrome. And how common is this condition in our clinical practice? I'm going to highlight to you the study that we have done in our UITM primary care clinic that was published in December 2020. So in this particular study, we actually recruited and analyzed 263 patients' data from our clinic with at least one risk factor for CVD. And astoundingly, we found that 54.4% of these patients actually have got Nafld. So it is true what Dr. Tan said just now, that we are actually going into Nafld pandemic at the moment, not just COVID-19 pandemic, but we also are facing with this, because in our clinic alone, more than half of the patients actually have got this condition. And this is actually confirmed with ultrasound by a radiologist. Only one radiologist was involved in this study, so it was very, very consistent finding. And in this particular study also, we found that there were 5 factors associated with Nafld. One is having, those who are working, those who are obese, those with high fasting blood sugar, those with high ALT, as well as those with high FRS in the high FRS category. So from this particular study, we recommended that patients with at least one CVD or Nafld risk factor should be re-stratified using the 10-year general CVD Framingham risk score, which is also the particular tool recommended in our primary and secondary prevention CPG for cardiovascular disease 2017. And we also recommend that if you find that the patients have got high FRS, obese, or have got elevated FPG or elevated LFT, ALT, then they should have ultrasound for Nafld. And as Dr. Tan mentioned just now, then the severity of the Nafld then should be assessed using non-invasive scoring such as FIT4 or NFS to identify those who need referral to the hepatologist. But regardless of this, regardless of whether they've got Nafld or not, these patients should be targeted for aggressive lifestyle intervention and risk factor management, which I'm going to talk to you this afternoon. So, ladies and gentlemen, just to share with you, this is the algorithm that has been agreed upon in our consensus statement on metabolic dysfunction associated fatty liver disease that we have sent for publication recently. Prof. Tan, UM, is the first author for this paper. It's currently under review by this Journal of Gastroenterology and Hepatology. So you can see here, patients aged more than 30 years old that comes to our clinic, then they should be assessed for components of metabolic syndrome and also assessed for the 10-year CVD risk using the FRS. And following this, then if they have this, then they should be screened for Nafld using ultrasound. And then if there is a presence of Nafld, then they should be assessed for liver fibrosis using FIT4 index, and then so on and so forth here, whether to refer to hepatology or not with the FIT4 cutoff of 1.3. But most importantly here that I want to stress to you, whether they have Nafld or not, yes or no, these patients actually need lifestyle advice and management of their multiple cardiovascular risk factors aggressively. So just sharing a bit of evidence on this, you can see here from this narrative review paper, looking at the effectiveness of lifestyle intervention in patients with Nafld in this randomized control trial. You can see here in the liver histology, there's improvement in many of these studies. 3 of these studies actually showed improvement in the liver histology following lifestyle intervention in these clinical trials. And there's also evidence for improvement in their cardiovascular risk factors. Regarding the recommendations of what to do with them regarding lifestyle intervention, across the Nafld diagnosis to NASH to cirrhosis, weight loss is the most important thing. So this is the thing that we have to actually emphasize to our patients, that they need to lose weight in order to improve their cardiovascular risk factors as well as liver pathology, so that it doesn't go into progression. So you can see here what is recommended is actually Mediterranean diet, encourage a regular meal pattern, avoid snacking, reduce alcohol intake, reduction in fructose and glucose intake, and reduction in the processed food. So this is for the fatty liver, as we know that fatty liver is still reversible. So we don't want them to progress into NASH or cirrhosis. And in terms of physical activity, what is recommended is increased daily physical activity level, about 10,000 steps per day, decrease total sedentary time and break up sedentary time, as well as to do aerobic or resistant exercise of moderate intensity of 150 minutes per week. So this is the recommendation recently from a narrative review paper, which is not much different from the recommendations in our 2017 guidelines for primary and secondary prevention of cardiovascular diseases. So the key points is, in the absence of approved drug therapy for Nafld, lifestyle intervention and aggressive cardiovascular risk factor management is key. So just sharing with you some practical tips of how to do this. This is what we do in our clinic in UITM. Previously, we have this book that we give to our patients for empowerment and self-management or self-care for our patients, because we believe that it is very, very important that our patients are empowered with knowledge and skills to change their behavior. And recently, we have completed our project of converting this particular booklet into a mobile app under the Prototype Research Grant Scheme. So with regards to this app, you can see here, there are 8 sections altogether. My profile, my cardiovascular risk, my treatment target, my checkup, my weight management to help patients to lose weight, my smoking habit, my self-management, and my medication. So what we can do using this app, especially for patients with Nafld, is first of all is to assess their metabolic syndrome components. So in this app, for this particular patient, for example, using the JIS definition, this particular patient has got fulfilled 5 different components of metabolic syndrome there. And the patient can actually save that, and so they know that they have all of these risk factors. In Malay, it's called penyakit 3, 4, 5 serangkai, and you can see here this particular patient of mine have got 5 serangkai. And then there's also a tick box for their diabetes, high blood pressure, with central obesity, as well as lack of physical activity here. And in this particular app also we have built in the general CVD Framingham risk scoring for easy use by the doctors and the patients as well. So all of these figures are actually automatically extracted from the data that we put into a desktop app that is used by the doctor. So the data is actually synced into this mobile app. So these figures actually comes automatically, and then you just have to fill up some of the things that needs responses, and you press calculate, and you get your risk scoring from this app. And then this is the interpretation here. So this particular patient, for example, is in very high risk with total points of 21 and the FRS score of 30%. And also we need to assess the target organ damage. So as I mentioned before, fatty liver or Nafld is actually one of the earliest target organ damage that we see in our patients with multiple cardiovascular risk factors such as this. So we really do not want them to have other complications such as heart attack, stroke, kidney damage, and so on and so forth. So this is what we have incorporated into the app as well, Nafld there you can see. And so in the following sections of the app here, we have the treatment targets directly from the CPG, 2017 CPG. And all of these figures are actually their actual clinic data that has been put into the desktop app that has synced into their mobile app. So patients can actually see their readings, the target which is set by the doctors together with the patient, and these readings then is generated into graphs. The red line there is the target, and that's the actual blood pressure. So in this particular case, this patient is doing quite well because the blood pressure is achieving target at the end. And we also have got the reward system here. This particular patient of mine is a 3-star patient. She achieved a target for blood pressure, blood sugar, and cholesterol, but she still needs to lose weight. So what she needs to do now is use a section of the app to help her to lose weight. There is BMI section there to calculate the BMI for the patient is also automatically extracted, this data, and also waist circumference there you can see, and also a formula how to lose weight in terms of their calories. So it is, for those patients who've got high health literacy, we can actually use this for calorie restriction, calorie counting, and so on, because we have got sections in this app where we can calculate the basal metabolic rate for the patients. This is a BMR. This is the calories that the patient can consume per day if the physical activity is sedentary. and the weight loss target then calculated with the patient, and this particular patient can actually achieve the weight loss target in 2 months if the patient actually follows the advice. And there's also graphs where patients can actually put in their weight at home, and it's generated into graphs as well. As also sections on the dietary advice, on simple advice such as the quarter half plate, and also examples of low calorie diet of 1,200 kilocal per day, because many of my patients would ask me, what they can eat with just 1,200 kilocal per day. So I say a lot you can eat. So this is one of the examples that we give, and also the types of exercise that they do and how much calories they can actually burn in half an hour. So this is just an example of what they can do at home. And also the section of the app have got the sections on self-monitoring at home of blood pressure monitoring, blood sugar monitoring, diet and exercise monitoring, as well as achievements. This is where the patients can actually put in their blood pressure generated into graphs as well, and to see whether their home blood pressure is achieving the targets or not, and as well as home blood sugar, food intake and exercise intake. So home blood sugar is also generated into graphs. Food and exercise intake is generated into calorie deficits per day. So if they achieve the calorie deficit of 250 kilocal per day, then they get a reward here. But this particular patient is not yet achieving the calorie restrictions that is recommended. And there's also one section for stop smoking, as well as the medications and which the patients are on. So ladies and gentlemen, this particular mobile app, as well as the desktop app, is actually being used in our UITM Primary Care Specialist Clinic in Selayang campus. At the moment, we are recruiting patients in our clinic to be using this app. And our clinic is going to move to Sungai Buloh campus in February 2022. And we are also doing an ongoing study as well to look at the usability of this app in clinical practice among our patients. And this is the research grant that we received to develop this particular app. And we've also recently received another £60,000 from UITM to do the usability study for this mobile app. And the conceptual framework for this study was developed based on the chronic care model, where we truly believe that there needs to be a productive interaction between our patients here and healthcare providers in order to improve cardiovascular risk factor management, and as well as to ensure effective lifestyle intervention. And our team has also published several more papers there related to this particular mobile app, and we have obtained or registered 9 copyrights with My IPO Malaysia. And Alhamdulillah, our team has won several research innovation awards for this. This is IDEX 2020 gold medals last year, followed by the gold medal in the International Invention Innovation Technology Exhibition ITEX 2021 at KLCC in December last year, 2021. So a bit of take-home message now. Nafld and CVD are both manifestations of end organ damage of metabolic syndrome. Nafld is highly prevalent in clinical practice, especially primary care in Malaysia. So we all should be screening and looking after it and then managing it quite well. And lifestyle intervention and cardiometabolic risk factors management are pivotal in patients with Nafld if we want to reduce their complications and progression to liver fibrosis. So with that, ladies and gentlemen, thank you very much for listening. Thank you.
Thank you, Prof. Anis, for the exciting lectures. We will take the questions after the webinars, and I encourage people who want to ask the questions, please feel free to write on the Q&A chat. As usual, if any medical treatment, lifestyle modifications not working, we will refer the patient to the surgeon, and it's an honor to have Professor Datuk Nik Rizal Kosai, the upper GI minimally invasive bariatric metabolic surgeon at the Hospital Chancellor Tuanku Mukris UKM here. So he's going to discuss about how the bariatric surgery in Nafld and Mafld, who are the patient and why. And Datuk Nik is currently the president for the Malaysian Metabolic and Bariatric Surgical Society, as well as a Malaysian chapter for the International Federation of Surgery for Obesity. is a very active member for the Malaysian Upper GI Surgical Society and well published in many journals. And without further ado, we will see our surgeon going to fix our patient who are not improve the standard of care. The stage is yours, Prof. Dato' Nick.
Good afternoon, everyone, and thank you, Prof. Raja, for the introduction, and thank you for the committee for inviting me to speak on bariatric surgery in Nafld and Mafld, who and why. So I have nothing to disclose except for everyone Malaysian with a normal BMI, there will be a doppelganger of a obese or overweight person, and for every 5 Malaysian, there will be one person who suffers with diabetes. And this is a tip of the iceberg. And this is one interesting experience with us. A 327 kilogram patient referred to us with multiple comorbidities, in particular, metabolic syndrome. Imagine we had to get the fireman to carry him. And fortunately, St. John's ambulance has an ambulance that was wide enough to carry him to the hospital. Took us nearly 6 weeks to optimize his condition, including a very low carry diet to reduce his liver volume. And this is what his liver was. And this was after we have reduced this volume size, 6 weeks before the operation. And he underwent sleeve gastrectomy and successfully. And this was at his discharge, the left picture. And this was when I just came across him at Village Grocery. I didn't actually recognize him. He recognized me. And subsequently, he has lost over 200 kilograms. And that is a surmountable weight to lose. And subsequent blood tests suggest that his liver function test has improved. Obviously, we have not done any fibroscan or any repeat ultrasound scan. Nevertheless, his quality of life has significantly improved since then. So the globicity is a problem nowadays. It kills more people than the underweight. So it's the new malnutrition. And in fact, WHO has categorized it as a disease. And our National Health and Mobility Survey also again highlighted the significant problem with obesity and in particular diabetes. And if you look at this newspaper cutting, virtually 50% of every state in this country's population is either obese or overweight. Now imagine virtually everyone who I have come across and did pre-op ultrasound scan have fatty liver, 100% fatty liver in all these obese population. Now, of course, the complexity of understanding the cause of obesity result in we are still fighting to fight this pandemic of globicity. Now, obviously, if we know, then there will be a magic pill and there will be no other treatment apart from this magic pill, and there will be no bariatric surgery. But at the moment, we probably only know about 20% of the natural physiology and pathophysiology of obesity. Now, everybody say, it's genetic, doctor. It's genetic. It runs in a family. But actually, this humor cartoon says it all. Obesity doesn't run in a family. The main problem is nobody runs in the family. So one of the complications of obesity, I can't emphasize anymore that obesity attracts at least 108 major medical problems. Okay. And of course, the main issue in this country is diabetes. And you can see the rate has increased significantly. Numerous newspaper cutting highlighting the problem, and yet people ignore. People still eat a lot. People still eat sweet stuff. And this is, again, lamented in this paper written by Dr. Zanaria. Again, highlighting the issue of non-compliance and how bad our diabetic control. If you can see in this study, type 2 diabetes in Asia Pacific, and in particular in Malaysia, has the HbA1c of more, above the target. So it's very poor control. And as a result, it causes a lot of complications. And as a result, it uses a lot of our health GDP. So again, the pathophysiology again comes from the combination of inflammation, insulin resistant, hypoxia, angiogenesis, and I'll speak to you again later with regards to immunity. And this actually eventually trigger the risk of developing cancer. Now, everybody knows the 5 main parameters that describe metabolic syndrome, but I still feel a non-alcoholic fatty liver disease or metabolic fatty liver disease should be the 6th component of metabolic syndrome. And again, the causes of Nafld, I think everyone know by now. And the 2 main problem is obesity, insulin resistant, and diabetes, and hypertriglyceridemia and hypercholesterolemia. Very rare causes like genetic causes, which I would probably unlikely to come across in my field. Now, this paper is interesting. It has come up with the concept of immunological complications of obesity. And just like cancer, that obesity increased the risk. There are 14 cancers, same as patient with liver, fatty liver, which eventually evolve into NASH, eventually fibrosis and cirrhosis. And the 2 main problem is because of this dysregulation of inflammatory process and the loss of apoptosis activation. So you get dysplastic formation and ultimately neoplasia, and as a result of these problems, cascades of problems. So imagine, these are all laparoscopic view of livers that I have operated on patient for bariatric surgery. It ranges from, you can see the top left, to cirrhotic huge liver. And imagine I have to operate on the stomach below it. So with using the liver retractor, and this is precisely why it's essential that before surgery, all these patients should be on very low calorie diet. And we normally put them on Legalon, interestingly, and omega-3 fatty acids also is beneficial, as we have published a randomized control paper, which I've not highlighted on this. But imagine the one on the right bottom. How, I need to go to the JOJ, which is quite higher up. So imagine such a huge liver, make the operations much more difficult. Now, of course, correlation of obesity and mortality is well described. So how do we treat obesity in general? Generally, the best medical treatment does not actually work that well in patients with morbid obesity, okay? Purely because of this hormone, which is produced by the fundic cells in the fundus of the stomach, which is a ghrelin. Now you can see the study that every time you lose weight, the baseline of ghrelin goes up, and ghrelin will stimulate our brain to ask us to eat. But the main culprit is obviously insulin. So it's what you take, and the volume that you take still matters. So you can see there's an array of ranges of treatment for obesity. And if you look in terms of surgery versus other medical treatments, surgeries obviously significantly win in terms of the best effective weight loss. So surgery has evolved since I think about 50 to 60 years ago. So it's not a new concept. It's been going on for many years. And it's divided into restrictive procedure, combination of restrictive and malabsorptive, and pure malabsorptive. We don't do that much malabsorptive operation in this country purely because the common channel is quite short. Hence, the risk of malabsorption is very high, especially protein and energy malnutrition. Nevertheless, these are the three commonest operations that we do in this country. Obviously, sleeve gastrectomy comes first, followed by Roux-en-Y gastric bypass and mini gastric bypass. And we do, these are the type of incision that we do. It's totally minimally invasive, and nowadays they get discharged the next day. Okay. We even do single incision surgery as well, as you can see on the left side picture. So I don't want to go too much about the technical aspect of the operation, but this is what sleeve gastrectomy look like. Is very easy operation, takes 45 minutes to an hour, very minimum risk and complications, very effective in weight loss. Gastric bypass, normally I would do in somebody with severe reflux or somebody with mild to moderate score for diabetes. With severe score, I just do sleeve gastrectomy because the chance of diabetic resolution is not as good as those who are still new with their diagnosis of diabetes. Now, of course, there are many other different types, at least 20 different types with modifications. Again, I don't want to go to a technical aspect. The reason why they do this is primarily to increase the weight loss, to reduce the risk of reflux, and of course, dumping, and to sort out the nutritional issues. The mechanism is simple. Basically, for sleeve, it's just purely restrictive. You take less volume, less calorie it is. And the mechanism for gastric bypass is in two mechanisms. One is the foregut theory. That means you bypass the duodenum jejunum where sugar, fat, and other nutrients get absorbed. With the small pouch, you eat less, so the absorption is less as well. And the hindgut theory is the speed of transit of food that reaches the distal eye lymph is faster. Hence, it increased the production of GLP-1 and peptide Y hormone, which stimulate the pancreas beta cell to increase the insulin, hence reduce the insulin resistant state. So the paradigm has shifted from the original aim of weight loss to now, because of the surmountable number and rate of diabetes in not only this country, in the world, plus metabolic syndrome. We are now focused more on sorting out not only weight, but also diabetic control, and aim also for diabetic resolution. I've written many articles, many papers, many editorials with regards to the shifting of the paradigm into metabolic. This is one of the example of the success for metabolic surgery, which is still a same synonym as bariatric surgery, but with a primary aim for treating diabetes as opposed to obesity. And you can see meta-analysis again show that the significant benefit, not only for high BMI, but also for lower BMI in terms of metabolic surgery in the resolution or improvement of diabetes as a whole. And if you look at the outcome in terms of improvement of diabetes or resolution of HbA1c and fasting blood sugar in comparison with best medical treatment, it is just comparable with the North American study, Asian study, and even our study, which we have published. There were a few papers on diabetic outcome after bariatric surgery in Malaysia. I was invited to be part of the Diabetic Surgical Summit in combination with our endocrinologists, in coming up with the guidelines, which has incorporated bariatric surgery as part of the treatment for obesity and metabolic problems. And they, of course, suggest that the earlier we do, the better. I would say so for a patient with Nafld or Mafld as well. So the indication of surgery, there are two cutoff points. One is WHO, one is Asian. We tend to follow the Asian, so we reduce the goalpost. We have actually published a paper on patient and procedure selection. You can actually read this, and these are the current indication for bariatric surgery in Malaysia. We do low BMI patients, however, or under the provision of clinical study, and has to be done in a university hospital. So it is very cost effective. It saves a lot of money in the long run, and it is very safe. So how does it work with regards to bariatric surgery in a patient with a fatty liver or non-alcoholic fatty liver disease? So this is basically the mechanism behind it. As you can see, I don't want to go much into detail, but you can actually obviously see reduction in weight, ghrelin in production, increased GLP-1, and hence reduced insulin resistance and reduction of all inflammatory parameters. Okay, and what are the evidence? Okay, so paper 1, okay, basically looking at the outcome in form of the 4 biopsy reports and the non-alcoholic fatty liver disease activity score. And as you can see, at least in patients with steatosis, 66% improvement, inflammation 50%, balloon degeneration quite significant, improvement of 76%, and fibrosis about 40%. And you can see a significant decrease in the NAS score. However, in the secondary outcome measure where they look at the worsening of Nafld, about 12% were worse, but this is explained by some of these patients, they did biliopancreatic diversion. So this is the one that the purely malabsorptive procedure. So obviously they result in protein malnutrition, and of course it can affect the liver function. But in general, bariatric surgery has significant benefit on Nafld and NASH, and they recommend that Roux-en-Y gastric bypass is the gold standard. Another paper again showed a significant improvement in steatosis, steatohepatitis, and fibrosis. Okay, up to 88% in steatohepatitis, and of course biochemical improvement as well. And again, the conclusion suggests that bariatric surgery confer a good histological and biochemical outcome, and Roux-en-Y gastric bypass still in favor as opposed to other procedures. Okay, and again, another systematic review suggests that the significant improvement on Nafld's outcome. In terms of cost effectiveness, regardless what the outcome of the liver function, nor the improvement of Nafld's fibrosis, ballooning, or so whatnot, okay, it still is cost effective because it solves other medical problems. When they compare between sleeve gastrectomy and Roux-en-Y gastric bypass, okay, it shows that again both confers a quite good outcome in terms of liver, in the aspartate aminotransferase to platelet ratio, which suggests the severity of the liver. However, interestingly, okay, there is negative correlation between weight loss and amelioration of the liver function. But this is explained because the number of diabetic patients in this cohort are quite high, and it does cause significant liver impairment pre-operative in the first place. Okay. Now, Cochrane Library also looked at the benefit and harms of bariatric surgery, but they could not make conclusion because the problem is the issue of ethical doing a diagnostic liver biopsy to confirm whether there is significant improvement or not in terms of the outcome of fatty liver. Okay, I'm nearly finished now. Okay, so they recommend that bariatric surgery needs further assessed, especially done in the randomized manner. Last of the slide, just to update you with regards to bariatric surgery in Malaysia. Okay, so the first operation was done in 1996, but at the time it was done in open manner. This is the history of progress of bariatric surgery we published. You can read this in obesity surgery. This is the Professor Mia was the first person who performed it, but if you can see the milestone of bariatric surgery, even our Director General of Health, Dr. Isham, performed the first sleeve gastrectomy, laparoscopic sleeve gastrectomy in 2003 in Hospital Putrajaya. Okay, so this is the current number of bariatric surgery performed in Malaysia since 1996, but you can see the number has increased quite significantly. This is our center. We have done to date more than 2,000 surgeries. Okay. This is the progress of our unit in UKM. We've done 2,075 bariatric surgery since I came and joined UKM in 2011. So in summary, I think this picture explained everything, but generally, virtually everybody with obesity will have Nafld or Mafld, and bariatric surgery has been proven to show the benefit in terms of not only weight loss, not only in terms of reduction in metabolic problem, but also reduction in improvement in liver function and improvement in progression of Nafld. So with that, I thank you very much, and sorry for the extra length of my talk.
Thank you so much for Dr. Nick for your presentation, and I'm going to read the questions and address to the speakers. I think the very first one, Prof. Chang Wakion can respond this about patient with diabetes and triple disease and raised liver enzyme and obese type 2 diabetes, and how is this, so overall, how we use, what's the tips and the tricks using statin in patient with raised liver enzyme? Prof. Chang.
Thank you, Professor Effendi. So I think there are several questions related to statin use in patients with Nafld or Mafld. I think I would like to take them together generally. So first of all, patients with Nafld or Mafld are at increased risk of cardiovascular disease. In fact, cardiovascular disease is the leading cause of mortality. Number two, we know that statin is a drug of choice in reducing LDL so that we can treat the patient's LDL to target based on their cardiovascular disease risk. And this can lower the cardiovascular event and mortality. However, statin is not known to cause liver injury, but serious liver injury from statin is really very, very rare. There is certainly under prescription of statin in patients with Nafld or Mafld. In fact, we did a study across several centers in Asia. We found that 75% of those Nafld or Mafld patients who should be on statin are not on statin. And in fact, among those patients who are on statin, 60% of them are actually not treated to target. So not only in Malaysia, but in other countries, it's the same problem. That's under prescription of statin. So as to the question of those patients with elevated liver enzymes, what to do? So you can actually find some guide in the clinical practice guideline for type 2 diabetes. Patient with elevated liver enzyme, we need to investigate for the cause. So we need to exclude common causes, for example, drug-induced liver injury, take a history, alcohol, whether there's significant alcohol intake, and also exclude a common cause like chronic hepatitis B and C infection. We order an ultrasound to diagnose fatty liver. And if we can be sure that the elevated liver enzyme is due to fatty liver, we will ask patients to go on a lifestyle change, aiming to lose at least 10% of their body weight, because most likely they have NASH when they have elevated liver enzyme from fatty liver. And we can repeat the ALT, AST in 3 to 6 months. We can expect some improvement. So in these patients, when we want to start them on statin, usually I don't start at the offset. I'll just ask them to go on lifestyle change first and repeat their fasting lipid profile after that. And at the same time, we would see some improvement if they have gone on lifestyle change, and we can see some improvement in their fasting serum lipid as well. And if they still require a statin, we will then start it. And although the liver enzymes are still elevated, we can start statin, but we need to monitor. So after starting, usually after a month, I'll repeat their liver function test and fasting serum lipid. If the liver enzymes go up more than 3 to 5 times, then it could be statin-induced liver injury. I will stop it, and then I'll repeat the test and see if it comes down. And usually I will re-challenge the patient to see if the same thing happens. If the same thing happens, then the patient should not be on the statin. But most of the time, when we actually start this patient on statin, we actually see improvement in their liver enzymes. And in fact, their cardiovascular disease risk will go down. If you are seeing the patient for the very first time, a fatty liver on a statin with elevated liver enzymes more than 3 to 5 times, you are not certain whether it's due to statin, you can always stop the statin and see whether there's improvement in the enzymes. Yeah, that will be my take on those several questions that we have on this issue. Thank you.
Thank you, Prof. Chan. A question to Dr. Tan Sok Siam. you mentioned, I think a lot of physician in the webinar, you mentioned about to diagnose NASH, we need to perform biopsy. I am sure in the near future, we have Nafld, then NASH. I'm sure there's a muffle, there's also MASH, you know. So do we really need to do liver biopsy? Dr. Tan Swet Siam, can you clarify with us for a diagnosis of the NASH or the future MASH?
Thanks. To diagnose MASH or NASH, you need the histology, the lobular inflammation, the ballooning, and also the Marie Dank bodies. Although there are a lot of studies on blood biomarkers on that, I'm not up to speed whether these, as far as I know, they are I'm still under research. There are certain biomarkers. Wakil, do you know whether these are used in, I think, remotely, not even in any clinical area, maybe in research?
At the moment, there's no a good biomarker that we can use routinely for diagnosing NASH. NASH is still a histological diagnosis, but there are emerging markers, that diagnose fibrotic NASH. That means patient with NASH, Nafld activity score at least 4 and fibrosis stage at least 2. But these are more for selecting patient for clinical trial. So I think if you really want to establish if the patient has NASH, you need a liver biopsy, but we don't do this routinely because a liver biopsy carries a small but serious risk of complication. And a lot of times we have patient with fatty liver, elevated enzymes. If they are able to go on diet, exercise, and lose weight, we will see improvement in their liver enzymes.
Can I actually elaborate a bit about the statins? The statin use is probably not a good idea when they're decompensated, especially Child-Pugh score C. That is because the mortality from the liver disease is very bad, and there is the prognosis is no good. That the use of statin is probably no use, and also there is a risk of higher risk of side effects, like especially rhabdomyolysis. And the other thing about statin use that it has been shown very repeatedly to be associated with the lower risk of hepatocellular carcinoma. It can actually also affect the portal hypertension. So if the patient needs a statin for the cardiovascular disease in the context of patients with liver cirrhosis, especially in Nafld and Nafld, I think we should use it. We should use it knowingly that actually there is other benefits like the hepatocellular carcinoma and the portal hypertension.
Just to add on for the liver biopsy as well. So usually we will do liver biopsy in somebody with fatty liver when we have doubt about the diagnosis. If there is a competing etiology, we suspect it could be NASH or autoimmune hepatitis or other etiologies. So we will do a liver biopsy to ascertain the reason for the liver function abnormalities. Yeah, we also sometimes do it if there's discordant non-invasive test result for fibrosis. And of course, in clinical trial, we would do a liver biopsy in most instances.
Thank you. I mean, in practical, it's very difficult to convince the patient unless for the diagnostic and staging purposes to do liver biopsy. I think you might agree because a lot of people refuse to have liver biopsy nowadays. And I think overall, the chances, or if you do the audit in all major hospital or any hospital, perhaps the liver biopsy is probably less reduced. Will you agree, Dr. Tan and Prof. Chan?
Yes, definitely. We used to do liver biopsy for all hepatitis C that we treat. Now it's not needed. As Professor Chan said, really we do it like when you're not too sure what's happening and whether there is another diagnosis that we need to entertain. Mind you, a lot of patients with Nafld has positive autoantibodies like ANA, SMA. So sometimes you do need a liver biopsy to tease out whether there is a concomitant liver disease on top of the Nafld.
Thank you. Question to Professor Dr. Anis. you show us a lovely mobile app for the empower and sustain self-management. And the now in the era of persuasive medicine, you know, people can enter all these details in the app and categorize you about this and that. So who's going to alert the patient that your patient cardiovascular risk is becoming increased? So, you know, and how the app can help the patient. Can you elaborate on that? Thank you.
Yes, sure. Thank you, Prof. Raja Effendi, for the very interesting question there. What I did not manage to cover in my talk is the app that I showed you is not meant to be used by the patients alone. It is designed to be used together with the doctor. That's the reason why we have not actually put in the app into Play Store, because it is actually not meant to be used by the patients alone. It needs the healthcare providers' input with it. So it is meant to be used during our regular follow-up. It needs that doctors' reinforcement in terms of its utilization. So when we actually calculate the Framingham risk score, it needs to be done with the patient. So the concept here is patient empowerment, doctor-patient relationship over a long time. So in our clinic, we actually emphasize on continuity of care, where patients actually see us, family physicians, over the years. Patients under my follow-up, for example, has been under my follow-up for the past 15 years, for example, and there is a very strong doctor-patient relationship there that has been built. So the app actually just to re-emphasize this relationship, that they need to be empowered with knowledge and skills to self-manage themselves. So there is no issue about FRS is high and doctor is not aware in this particular app that I showed you, because it's calculated with the patient. It's not auto-calculated by the machine. So that's the answer. Okay,
thank you. Prof. Anis, in your practice, do you prescribe exercise? Do you give exercise prescription to the patient? Can you share with us?
Yes, I do, but it depends on patients' motivation. In order for any lifestyle intervention to be successful, first of all, we need to assess their motivation, and number two is their health literacy. So for patients who are highly motivated, who wants to lose weight and have got high health literacy level, that is able to receive exercise prescription as well as dietary prescription, then I do. So I go into detailed calorie counting with the patients on how to calculate their calorie per day. So there are many other apps in the market that can do that, like for example, MyFitnessPal, that has got database of Malaysian food that the patients can actually use to calculate calories that they take. And also now I think we're waiting for apps, what we call image processing. It is not available in the market yet, but I know some colleagues is working on it, where patients actually can take pictures of their plate and upload it into the software, and the software will automatically calculate the calories. So it's using the AI technology, but it's not yet available because of the accuracy of the data. And as well as that, in terms of exercise as well, we know that there are many apps out there that can be used by patients, for example, Fitbit. If the patients are highly motivated, I would actually advise them to wear exercise watch and monitor their calories that they burn per day. And with that, then we have an accurate, more accurate calories in and out per day in order to guide their weight loss. So I mean, the patients in my clinic varied. We've got people from one end to the other. So, but however, those who are with less motivation and literacy, then I normally go with simple advice like quarter, half plate, for example. So it really depends on the patients. And we've got success rates as well in our clinic in terms of weight loss. I've got patients who has lost 8 to 10 kilograms of weight over 6 months to a year, and able to sustain the lifestyle change that they do. Thank you.
Thank you, Prof. Anis. Question to Prof. Datuk Nick. In your experience so far dealing with the very obese patient for bariatric surgery, what is the overall acceptance among Malaysian patients who planning to go the bariatric surgery? Do they give you the hard time, or they really want to go this? And in your cohort, for example, how many of them will actually go back to the bad habit and grow obese again after 6 or 12 months of surgery? Can you comment on this?
As you can see, the number of bariatric surgery has increased over the last decade, and this is purely because of patient awareness. Not only just the patient awareness, general public awareness, but also all the medical professional awareness. And I get a lot of referrals now, even from endocrinologists, for purely to do metabolic surgery for a patient who is fully controlled diabetes on insulin up to the hundreds of units, with a very poor HbA1c. Now, of course, these kind of patient needs to be counseled properly, because we cannot give them false hope and too much expectation. And just like any paper that's been published all this while, evidence suggests that the earlier you do, the better. And that means the earlier diabetes you do, the better, because it's all come to the beta cell functionality. And I always do a patient who has diabetes for more than 10 years to do at least the C-peptide levels. And if the C-peptide level is very high, then it gives you a better prediction with regards to the chance of diabetic resolution at 1 year. So that means their HbA1c, fasting blood sugar, without requiring any anti-diabetic medication, the fasting blood sugar HbA1c is normal at 1 year. So that means you have resolved your diabetes. But whatever it is, it all depends on the duration. So if it's less than 5 years of diabetes, the chance of complete resolution is 100%. But if it's more than 10 years, it's probably about 50 or less %. But in terms of improvement, regardless of how long they have diabetes and what their C-peptide level is, it's for improvement, 100%. Now, the second question is regarding weight recidivism or weight regain. So basically, all studies showed that after bariatric surgery, 87% of patients with bariatric surgery will experience weight regain. Okay, but weight regain of 5 to 10 kilos is considered normal after bariatric surgery. Now, again, counseling before operation is very important, because they need to understand and be aware that bariatric surgery is just a modality that will help them reduce weight at the real time. That means at the time of they come and see us. Okay, they have to understand that. And why they come and see us? Because they have attempted other means of ways to lose weight and has failed. And also they have has other comorbidities that is uncontrolled. So basically, they have to understand that they will definitely lose a lot of weight. Okay, their metabolic problems or other medical problems like arthritis will improve significantly. Quality of life will improve significantly. But at the end of the day, in terms of maintenance and durability of success of bariatric surgery, it's still essential that they have to change. You know, if you're going to change, everything has to change. You know, their lifestyle has to change. So that means the way of their diet habit has to change, and they need to exercise. And obviously, common sense says that if you have lost 40, 50 kilos, it makes you much easier to exercise. You should love to exercise from there on. Okay. If you don't, then the chance of weight regain will go up. Now, I also tell them, you know, because they always ask, Doctor, what's the chance of weight regain? Because if there's a chance of weight regain, there's no point I'm doing the operation. Well, this is why I said, you know, we are treating you at real time at what your problem now. So if we don't treat you now, you might not be around in 2 or 3 years' time. So whatever it is, improvement is 100%. But in terms of a guarantee for success, 100% success is not always there unless the patient is a well-motivated and was going to be very adaptive to their new change and implement a very healthy lifestyle.
Okay, thank you. It looks like we all have to do one-stop center clinic. Prof. Anis, go to you, pass to Chang Wah Kiong, pass to Siam, pass to endocrinologists, and eventually not working, pass to Dr. Nick for whatever. It looks like the creation of one-stop center, and of course with dietitian and nutrition. Now, I found it very difficult sometimes. I mean, we are not trained nutritionists or dietitian. You know, when we mention Mediterranean diet, the patient might throw the pen to us. It's a bloody expensive and not acceptable. How are you going to get all this lovely, nice olive and to eat? So we may have some need to create a Malaysian healthy diet also. You know, I mean, quarter and a half, yes, we can do that. But I think it's a great, I think we would like to thank you to all the speakers, a great sharing all the cases and all the experience and the evidence base. I hope we are not muffled anymore. So we know exactly what Nafl and muffle is. We move forward. With that, again, I thank you so much for your participation, and I pass back to Dr. Chan. Dr. Chan, back to you.
Yes, thanks, Prof. Raja Effendi. Thanks to all the speakers for such an excellent webinar. Thanks everyone for joining us. Don't forget to join us again next Thursday. There will be a QR code share shop